The quiz question for this session is, according to the study by Beaton, Dr. et al., GUT 2024, approximately what percentage of gastroscopies were performed on patients with a cancer risk of less than 1%? Is it 25, 50, 60, 75, or 90%? So please let us know what you think the answer is. The first person to answer this question correctly, who has entered their email address in the online platform, because if you don't, you won't get any GIEQs coins, will win 10 GIEQs coins. And we are so fortunate and so privileged as an organization to have enlisted the help of some key opinion leaders in the field of gastroscopy to participate with us in generating a curriculum for diagnostic gastroscopy. And I think that this is something really important. John, Roland, and I feel that this is something very important that is an empty space out there, and which can really, hopefully, revolutionize the situation with both knowledge acquisition, but critically technical skill acquisition in upper GI endoscopy. In 7 minutes, I want to recognize the key information that you need to share before performing a gastroscopy with patients. You need to anticipate poor patient tolerance and use mucolytic agents to improve visualization. And really, I want to drill down on what in this curriculum will become very important, which is there are specific indications where gastroscopy is at greater risk of finding the precursors of upper GI cancer. These are the procedures where you should focus your resource, focus your attention, and not consider a suboptimal examination to have been complete for the patient. Consent, I don't really want to cover in detail. There are great documents both from the BSG and the ESG, but the principles are important. But what we will not focus on today. What about enhancing awareness of high cancer risk indications? Well, this very nice article just published in GUT, which talked about the diagnostic yield of symptomatic gastroscopy. It's from the National Endoscopy Database in the UK. Huge number of gastroscopies analyzed, and the positive predictive factors for cancer were highest in patients over 50 with dysphagia or with weight loss plus one other symptom. The cancer yield, as we've said, was highest in elderly male patients and those over 50. 3/4 of gastroscopies were performed on patients whose cancer risk was under 1%, suggesting inefficient resource utilization. Now, of course, that doesn't mean that doing gastroscopy on these people is wrong. But it also does mean that if you're doing gastroscopy to rule out cancer on these patients, you should maybe consider whether that is the right thing to do or whether that is the right. I already said that. Also, what I think is very interesting is factors predicting poor tolerance. So what factors predict poor tolerance in gastroscopy? So I think we all know this. This is all very much like something that if I asked you for what predicts, but at least someone did a study on it, right? And shows that age under 40, okay, I think we realize that. Was this something just in this study? I'm not sure. Body mass index over 25, hiatal hernia, procedural sedation, we all recognize that, I think, not propofol, but midazolam and too much of it, and a high level of anxiety. Almost all of these predict poor tolerance, and if you have these, you should be thinking about it.